Hello everyone, my name is Artur Baranetsky and today I'll be presenting a CE credit on current trends in COVID-19 treatment that me and my partner Nabil Kayan worked on for the past couple weeks. The presentation was reviewed by Dr. Stephanie Bevino and Dr. Tatiana Grishaber. There are no financial interests or relationships to disclose. So some learning objectives for today. Today we're going to identify vaccines and medications used to prevent COVID-19. We're going to evaluate therapeutic management for non-hospitalized and hospitalized adults. We're going to review medications used to treat COVID-19 and important clinical perils of each. And finally, we're going to recognize medications that are no longer in use for treatment of COVID. We're going to start off by taking a look at vaccinations and pre-exposure prophylaxis for COVID-19. So for the COVID variants, we have certain variants of concern such as Delta, Omicron, and more specifically for Omicron, there are subvariants that are of significant importance as they're currently spreading worldwide. So some important subvariants of Omicron are BA2, B11529, and XE. There are certain variants that are also currently being monitored, but are not variants of concern just yet. Those include Alpha, Beta, Gamma, Kappa, Lambda, Mu, and others. Taking a look at the vaccination schedule. So this slide here shows you the main vaccines that are currently being used in the United States, and those include Pfizer, Moderna, and Janssen. Starting with the Pfizer pediatric vaccine. It's an mRNA type of vaccine, and the first dose is 0.2 milliliters. The second dose is 3 weeks after the first dose, and it's also 0.2 mL as well. No booster is currently recommended for this age group, and the age group that this vaccine is indicated for is 5 to 11 years old. Moving on to Pfizer adult vaccine. It's also an mRNA type of vaccine. The first dose is 0.3 mL, followed by another 0.3 mL dose 3 weeks after the first dose. The booster for this vaccine is also 0.3 mL, and it's indicated for 5 months after the second dose. The age group that it's indicated for is 12 years or older. Next, we have Moderna, which is also an mRNA vaccine type of vaccine such as Pfizer. The first dose for Moderna is 0.5 mL, while the second dose is 4 weeks after the first dose, and it's also 0.5 mL. The booster is recommended to be given 5 months after the second dose, and it's 0.25 mL. Moderna is indicated for patients that are 18 years or older. Finally, we have Janssen. Janssen is a viral vector type of vaccine. The first dose is 0.5 mL, and there is no second dose recommended. For a booster, we can either do Pfizer or Moderna 2 months after the first dose of Janssen. Janssen vaccine is also indicated for patients that are 18 years or older. There are also certain vaccines that are used outside the United States. This table here shows the vaccines that are used out of the United States, what type of vaccine they are, the dosing, and what countries are they available in. Starting off the list with Oxford AstraZeneca. It's a viral vector type of vaccine. It's a 2-dose series, 0.5 mL each, given 8 to 12 weeks apart. This vaccine is available in Europe, Africa, South America, Middle East, Canada, and Australia. Next, we have Confidencia. This is a viral vector type of vaccine. It's a 1 dose of 0.5 milliliters intramuscularly, and it's available in China, Europe, and Latin America. Next on the list, we have Sputnik V, which is a viral vector vaccine as well. It's a 2-dose series, 0.5 mL each, given 3 weeks apart. This one is mostly available in Russia, South America, Africa, and Asia. Moving on to Sinopharm, which is an inactivated type of vaccine. It's a 2-dose series, 0.5 mL each, given 3 to 4 weeks apart, and it's mostly available in Asia, Africa, and Latin America. Next on the list, we have Sinovac. Sinovac is an inactivated type of vaccine as well. It's a 2-dose series, 0.5 mL each, given 2 to 4 weeks apart. This one is available in Asia, Africa, Latin America, and Ukraine. Next on the list, we have Nuvaxovid and Covovax. Those are the subunit type of vaccines that include 2-dose series, 0.5 mL each, given 3 to 4 weeks apart. They're mostly available in Canada, Australia, India, and Europe. And finally, we have Pfizer and Moderna. Both are an mRNA type of vaccine. The dosing we previously discussed on the last slide, and these vaccines are available worldwide. On this slide, we see the only medication that's been authorized for pre-exposure prophylaxis of COVID-19 under FDA EUA. The medication is tixagevimab plus cilgavimab, or Evusheld. This medication is indicated for pre-exposure prophylaxis for patients that are at least 12 years old and weigh at least 40 kilograms. Also, there has to be a confirmation that the patient does not have COVID and have not been recently exposed to COVID and are moderately to severely immunocompromised or not able to be fully vaccinated. The dosing for this medication is 300 milligrams of tixagevimab and 300 milligrams of cilgavimab as 2 separate IM injections. The adverse events include dizziness, fatigue, headache, insomnia, and cough. It's important to monitor and observe an individual for at least 1 hour after injection for any kind of hypersensitivity reactions. The contraindications for this medication include individuals with previous severe hypersensitivity reactions, including anaphylaxis to any component of Evusheld. For warnings and precautions, we have cardiovascular events, such as myocardial infarction and cardiac failure, and also hematologic events. So we want to use this medication with caution in patients with thrombocytopenia. This medication is administered IM, and it exists in a concentration of 150 milligrams per 1.5 mL in a single dose vial. Also, if a person has received a COVID-19 vaccine, Evusheld should be administered at least 2 weeks after the vaccination. Okay, so to wrap up the vaccination and the pre-exposure prophylaxis section, I have a quick knowledge check. So which of the following vaccines is not available in the United States? A, Pfizer, B, Janssen, C, Sputnik 5, and D, Moderna. Just take a minute to look over the question and come up with your response. Okay, so the correct answer for this question is C, Sputnik 5. As we've seen on the previous slides, Pfizer, Janssen, and Moderna are used worldwide, but primarily they're used in the United States. Sputnik 5 is a Russian vaccine, and it's primarily used in Russia and Asia. In this next section, we're going to discuss therapeutic management of non-hospitalized adults with COVID-19. Risk factors are important to consider for patients that have COVID-19, as depending on the severity and the number of those risk factors, we can actually choose a more appropriate therapeutic regimen for that specific patient. So, risk factors for progression to severe COVID-19. On this slide, you see a variety of risk factors that can be present in a person with this infection, and they can have a detrimental effect on the patient's health. So one of the most important risk factors is age more than or equal to 65 years old. More than 81% of COVID-19 deaths occur in people more than 65 years old. So as you can see, that's a very important risk factor to consider in this patient population. Obesity is also a very important risk factor, as it may triple the risk of hospitalization from COVID. Some other ones include chronic lung disease, hypertension, and cardiovascular disease. As you can see, certain ones are bolded while others are not. The bolded ones have a more of a detrimental effect on the patient and are a sign of poor prognosis as well. The other ones can have an impact as well, and those include pregnancy, diabetes, BMI over 25, smoking, and sickle cell disease. So on this slide, you see an outpatient treatment summary or an outline that basically depicts of where do we begin and where do we stop for patients that are in the outpatient setting. So starting from the left, a patient presents with mild to moderate disease with confirmed COVID-19. So we clinically observe this patient and provide supportive care such as pain relievers or fever reducers, depending on what the patient needs. Then it's important to consider those risk factors that we've talked about on the previous slide. So patients that have severe risk factors, and a number of those risk factors can be considered as high-risk patients. And for those patients, we can consider some certain medications as well. Those include Paxlovid, Remdesivir, Bebtelovimab, Molnupiravir, and Sotrovimab. Okay, so let's take a closer look at the treatment guidance for an outpatient setting. So if the patient is more than or equal to 12 years old and weighs at least 40 kilograms, we have this guidance that's depicted on the slide that basically helps us see where do we start and where do we end in regards to therapeutic regimens for these patients. So starting at the top in this box right over here. So symptom onset within the past 5 to 7 days. If the answer is no, then we're basically treating the patient's symptoms right over here on the right side. If the answer is yes, that the symptoms did begin within the past 5 to 7 days, then we have to ask some follow-up questions such as, is eGFR less than 30 milliliters per minute, or is the patient in the child PU Class C category? If the answer is yes to either one of those, then we have some possible options for this patient. The options include sotrovimab 500 milligrams IV or bebtelovimab 175 milligrams single IV injection. After giving those medications to the patient, we have to consider were those medications clinically effective. If they were not, then we have some follow-up questions to ask as well, such as, is the patient more than or equal to 18 years old, and is the pregnancy ruled out? If the answer is yes to both of those questions, we have another option that we can use right over here. And the option is molnupiravir 800 milligrams by mouth every 12 hours for 5 days. Coming back to this box over here that we talked about, eGFR less than 30 or child PU Class C category. If the answer was no to either one of those, then we have some other options for this patient as well, such as Paxlovid or sotrovimab 500 milligrams IV, or we can do remdesivir 200 milligrams IV on day 1, then 100 milligrams IV on days 2 and 3. After choosing a therapeutic option here, we also have to consider were those medications clinically appropriate or effective for this patient. If the answer is no, there are two ways we can go about this. We can either go left or we can go down here. Okay, so let's go left first. If those medications were not clinically appropriate for the patient, we have to ask a follow-up question. Is the patient more than 18 years old? And is the pregnancy ruled out? If the answer is yes to both of those questions, then we can also consider molnupiravir 800 milligrams by mouth every 12 hours for 5 days. Then we have another option as well if none of these medications above right here were clinically appropriate or effective in the patient. Another option we have is bebtelovimab 175 milligrams single IV injection, as you can see right over here on the bottom. After this medication, if the patient is still experiencing symptoms and the medications that we used previously were not effective, we can head right over here and focus on treating the patient's symptoms. On this slide, we also have a treatment guidance for an outpatient setting, but here we're focused on a different patient population. So for this slide, our patients are less than 12 years old and weigh more than or equal to 3.5 kilograms, but less than 40 kilograms. So for this patients, we follow this guidance that's depicted on this slide. So here we start on the left side. So symptom onset within the past 7 days. If the answer is no to that, then we focus on just treating the patient's symptoms. If the symptom onset was within the past 7 days, then we have to follow up with some other questions as well. So is the patient more than 28 days old with eGFR less than 30 mLs per minute, or is the patient 7 to 28 days old with serum creatinine more than or equal to 1? If the answer is yes to either of those questions, then we just focus on treating the patient's symptoms. If the answer was no, then we can slide over here to the right, and this is the option that we have for this patient. So we can consider remdesivir 5 milligrams per kilogram IV on day 1, followed by 2.5 milligrams per kilogram on day 2 and 3. Okay, so let's take a closer look at the medications that are used in the outpatient setting. We'll start off with ritonavir-boosted nirmatrelvir, or Paxlovid. This medication has been approved or authorized for mild to moderate COVID-19 in high-risk individuals aged more than or equal to 12 years old and weighing at least 40 kilograms. So starting off with the dosing. So dosing is based on eGFR. So if eGFR is more than or equal to 60, our dose is nirmatrelvir 300 milligrams with ritonavir 100 milligrams twice daily for 5 days. If eGFR is more than or equal to 30 but less than 60, our dose is nirmatrelvir 150 milligrams with ritonavir 100 milligrams twice daily for 5 days. Finally, if eGFR is less than 30, this medication is not recommended. There are also some important considerations regarding liver function. So dosing based on hepatic function. For patients in a child PU class A or B, there are no dosage adjustments necessary. If the patient is in a child PU class C, this medication is not recommended. Some important adverse events to consider for patients that take this drug are hepatitis, myalgia, hypertension, diarrhea. Some important monitoring parameters are liver function test, creatinine clearance, serum creatinine, and blood pressure. There are also two important contraindications to take a look at, and that includes a history of hypersensitivity to nirmatrelvir or ritonavir or any other component of the product. Also, concomitant use with CYP3A4 inducers and inhibitors is not recommended at all, since this medication is metabolized by CYP3A4 and that could possibly lead to some drug interactions. Those drug interactions include amiodarone, phenytoin, carbamazepine, phenobarbital, oral midazolam, and St. John's wort. Some other important considerations regarding this medication. So this medication is administered by mouth. Ritonavir is metabolized by CYP3A4 and CYP2D6. If you miss a dose, take a missed dose if within 8 hours of the time it is usually taken. This medication exists in a concentration of nirmatrelvir 150 milligrams plus ritonavir 100 milligrams. And we want to make sure that we initiate this medication within 5 days of symptom onset. The next medication we're going to talk about is remdesivir or Vaclury. This medication is approved for treatment of COVID-19 in individuals that are over or equal to 12 years old and weighing at least 40 kilograms. So starting with the dosing. So adults and children age more than or equal to 12 years old and weighing more than or equal to 40 kilograms. Our dose is 200 milligrams IV on day 1, then 100 milligrams IV once daily from day 2. For children weighing 3.5 to less than 40 kilograms, we want to make sure we use the lyophilized powder, and the dosing is as follows. 5 milligrams per kilogram IV on day 1, and then 2.5 milligrams per kilogram IV once daily from day 2. The total treatment of duration also depends on where the patient is being treated. So for non-hospitalized patients, the total duration is 3 days, while for hospitalized patients, the duration of treatment is 5 days or until hospital discharge, whichever comes sooner. Some important adverse events to look at include bradycardia, anaphylaxis, increase in serum glucose, nausea, and increase in ASTs, ALTs, and bilirubin. Some considerations regarding monitoring. So we want to monitor for infusion reactions during the infusion and observe for at least 1 hour after infusion. Some other ones include heart rate, liver function test, creatinine clearance, and serum creatinine. There are also a couple of precautions regarding this medication, and those include that it should not be initiated in patients with ALTs more than or equal to 5 times the upper limit of normal. It's also not recommended for use in patients with eGFR less than 30 milliliters per minute. For contraindications, we have patients with history of clinically significant hypersensitivity to Vaclury or any components of the product. This medication is administered IV over 30 to 120 minutes. It's metabolized by CYP3As and CES1, and it exists in 2 different concentrations. So we have the lyophilized powder, which is 100 milligrams, and that is used for patients that are under 12 from 3.5 to 40 kilograms. And then we also have the injection concentration, which is 100 milligrams per 20 ml or 5 milligrams per 1 ml, and that is used for our adult patient population. We also want to make sure that we initiate this medication within 7 days of symptom onset. Okay, so next we have sotrovimab. This medication is used for patients that are more than or equal to 12 years old and weigh at least 40 kilograms. The dose for this medication is 500 milligrams administered by IV infusion over 30 minutes. There are no dose adjustments necessary for renal impairment, and the effect on hepatic impairment is unknown. Some adverse events we have here are rash, diarrhea, and hypersensitivity, including anaphylaxis and infusion-related reactions. Due to that side effect, we want to make sure that we monitor patients during IV infusion and for at least 1 hour after. A contraindication for this medication is a history of anaphylaxis to sotrovimab or any component of the formulation. For administration, it could be administered IV over 15 minutes for a 50 ml infusion bag or for 30 minutes for a 100 ml infusion bag. Metabolism for this drug is via catabolic pathways, which basically breaks the drug down into smaller components that can be then excreted. The medication exists in a 500 mg per 8 milliliter solution in a single dose vial, and it's important that we initiate this drug within 7 days of symptom onset. One final consideration regarding this is that it has reduced neutralizing activity against the Omicron BA.2 variant. That is a very important consideration regarding this medication, since most of the cases nowadays are due to the Omicron variant. So we would have to consider, would this medication be effective for that specific patient or not? Next, we have bebtelovimab. This drug is used for patients that are more than or equal to 12 years old and more than or equal to 40 kilograms who are at high risk for progression to severe disease and or hospitalization. The dose is 175 milligrams IV once. There are no renal dose adjustments necessary, and there are no dose adjustments for mild hepatic impairment as well. Some adverse events include pruritus, skin rash, nausea and vomiting, and infusion-related reactions. Due to those infusion-related reactions, we have to monitor the patient for at least 1 hour after injection for those reactions. There are no contraindications that have been identified based on the limited available data for emergency use, and this medication is administered IV over 30 minutes. It's metabolized via catabolic pathways into peptides and amino acids, and it exists in a concentration of 175 milligrams per 2 milliliters in a single dose vial. We also want to make sure that we initiate this medication within 7 days of symptom onset. The last medication we're going to talk about in the outpatient setting is molnupiravir, or Lagevrio. This medication is authorized for mild to moderate COVID-19 in high-risk individuals that are more than or equal to 18 years old. The dose is 800 milligrams, which is 4 200 milligram capsules by mouth every 12 hours for 5 days. There are no renal or hepatic dose adjustments necessary. The adverse events include skin rash, anaphylaxis, diarrhea, nausea, and dizziness. For monitoring parameters, we want to make sure that a pregnancy test is done prior to initiation, and we also want to monitor for signs and symptoms of hypersensitivity. There are also some precautions that exist and are very important in regards to this drug. Those are that it's not recommended for use during pregnancy. Breastfeeding is also not recommended during treatment for 4 days after final dose, and it is also not authorized for patients that are less than 18 years old due to effect on bone and cartilage growth. There have been no contraindications identified based on the limited available data. This medication is given by mouth, and its metabolism is it's a prodrug that's metabolized to N-hydroxycytidine, and it exists in 200 milligram capsules. We also want to make sure that we initiate this medication within 5 days of symptom onset in order to ensure that it's effective. Okay, moving on to adjunctive therapy. So ACE inhibitors, statins, NSAIDs, and oral inhaled and intranasal corticosteroids that are prescribed for comorbid conditions should be continued as directed. In patients with HIV, antiretroviral therapy should not be interrupted. There is insufficient evidence to recommend for or against supplements such as vitamin C, vitamin D, and zinc. But we want to make sure that we recommend against using zinc supplementation above the recommended dietary allowance. There are also certain medications that are no longer recommended for use in an outpatient setting. Those medications include lopinavir plus ritonavir combo, inhaled corticosteroids, ivermectin, and fluvoxamine. There are also certain medications that are no longer recommended for post-exposure prophylaxis, and that's due to the fact that they're ineffective against the Omicron variant. Those include the combo of casirivimab and imdevimab, and the combination of bamlanivimab plus etesevimab. So to wrap up the therapeutic management of non-hospitalized adults with COVID-19, I have this other quick knowledge check as well. So the question is, which of the following risk factors has been associated with more than 81% of COVID-19 death? The options are A, age over or equal to 65 years old, B, hypertension, C, diabetes, and D, obesity. Just take a quick minute to look over the question and the answers and come up with your response to this question. Okay, so the answer for this question is A, age over or equal to 65 years old. As we discussed it previously on the other slides, risk factors are very important to consider for patients with COVID-19, as we can use those risk factors to pick out a therapy regimen that will be more beneficial for our patient population. Other risk factors such as hypertension, diabetes, and obesity are also very important to consider, but they're not the ones that have been associated with more than 81% death in patients with COVID-19 infection. Okay, next we're going to talk about the therapeutic management of hospitalized adults with COVID-19. The World Health Organization has a classification system of COVID-19 severity, which can help us select an agent depending on how severe the infection is in the patient. So for patients with mild COVID-19, there is an absence of signs of severe or critical disease. You'll see those signs are listed below. So for moderate disease, oxygen saturation is less than 90% in room air, there are signs of pneumonia, and there are also signs of severe respiratory distress. For the severe category, the patient requires life-sustaining therapy. It could possibly be an acute respiratory distress. The patient could have sepsis, which could possibly then lead to septic shock. Okay, so first we're going to talk about the inpatient treatment guidance for non-severe disease. Okay, so if a patient is hospitalized with confirmed or suspected COVID-19 without any severe disease criteria, we're going to clinically observe the patient and provide supportive care as needed, such as fever reducers, pain relievers, or fluids. We can also consider giving the patient remdesivir for up to 3 days. It's important to note that it is recommended against the use of dexamethasone or any other corticosteroid in this specific patient population. Next, for patients without evidence for venous thromboembolism, we recommend a prophylactic dose of heparin unless contraindicated. This slide depicts an inpatient treatment guidance for severe disease, but for the patients that are not intubated. So starting on the left, patient has confirmed or suspected COVID-19. Does the patient have one of the following? Oxygen saturation less than or equal to 94% in room air, or does the patient require supplemental oxygen? If the answer is yes to either of those, we provide the patient with supportive care, and we ask a follow-up question. Does the patient require supplemental oxygen? If the answer is yes to that, then we have some therapeutic options that could be given to this patient. Those options include dexamethasone 6 milligrams by mouth or IV every day for 10 days. Some alternatives that exist for dexamethasone are prednisone, methylprednisolone, and hydrocortisone. Another option would include remdesivir for 1 to 5 days, or we can do a combination of dexamethasone plus remdesivir. If either of those options is not clinically effective, we can also consider some other agents, such as tocilizumab or baricitinib. An alternative for tocilizumab would be sarilumab, and an alternative for baricitinib can be tofacitinib, as some other options that could be used in this patient population. Moving down to the next category. For non-pregnant patients who require low-flow oxygen with D-dimer more than the upper limit of normal, who are not at an increased risk of bleeding, we recommend a therapeutic dose of heparin. For other patients, we recommend a prophylactic dose of heparin unless contraindicated. Finally, we have the inpatient treatment guidance for patients with severe disease that are intubated or on ECMO. So starting on top, this patient has confirmed or suspected COVID-19. we want to ask, does the patient has one of the following? Does the patient require mechanical ventilation, or does the patient require ECMO? If the answer is yes to either of those, we provide the patient with supportive care, followed by dexamethasone 6 mg by mouth or IV once daily for 10 days. And if that is not clinically effective, then we can also consider giving the patient tocilizumab or baricitinib, with alternatives such as seralutinib or tafasitinib that exist for those medications. For patients that do not have a confirmation of a venous thromboembolism, we recommend a prophylactic dose of heparin unless contraindicated. An important consideration here is that if a patient is started on a therapeutic heparin dose before transfer to the ICU, we want to switch to a prophylactic dose of heparin unless there is a non-COVID-19 indication. Okay, so let's take a closer look at the medications that are used in an inpatient setting. First, we have dexamethasone. The dose of dexamethasone is 6 mg IV or PO once daily for up to 10 days or until hospital discharge, whichever comes first. And alternatives for this medication are methylprednisolone 32 mg daily, prednisone 40 mg once daily, or hydrocortisone 160 mg daily. The adverse events list is pretty extensive for this medication, and it includes hyperglycemia, secondary infections, reactivation of latent infections. We can have psychiatric disturbances, increase in blood pressure, peripheral edema, and myopathy. Due to all these adverse events, we have a larger range of monitoring parameters, and that includes blood glucose, serum potassium, hemoglobin, signs and symptoms of a new infection, and blood pressure. A contraindication is hypersensitivity to dexamethasone or any component of the formulation. For this specific patient population, this drug is administered either by mouth or IV, and it's metabolized hepatically via CYP3A4, which can tell us that there could possibly be some certain drug-drug interactions with other drugs that are also metabolized by CYP3A4. The next class of drugs that is widely used in an inpatient population are the interleukin-6 or IL-6 inhibitors. The indication for this class is for hospitalized adults and pediatric patients more than or equal to 2 years old who are receiving systemic corticosteroids and require supplemental oxygen, non-invasive or invasive mechanical ventilation, or ECMO. For uses, this class of medications can be used in combination with dexamethasone plus remdesivir for patients with severe disease requiring mechanical ventilation. Tocilizumab should not be used in combination with baricitinib. Treatment with a combination of IL-6 inhibitor with corticosteroids appears to be the most effective when given within 2 days of admission. We also want to recommend against the use of IL-6 therapy on inflammatory marker levels alone. Okay, so the first IL-6 inhibitor that we're going to take a look at is tocilizumab, or Actemra. This medication is used for hospitalized patients that are more than or equal to 2 years old, and the dose is based on body weight. So if the patient is less than 30 kilograms, the dose is 12 milligrams per kilogram administered by IV infusion over 1 hour. If the patient weighs more than or equal to 30 kilograms, the dose is 8 milligrams per kilogram administered by IV infusion over 1 hour. The max dose that can be given is 800 milligrams. If clinical signs or symptoms worsen or do not improve following the first infusion, one additional dose may be administered at least 8 hours after. For renal dose adjustments, there are no adjustments necessary if the patient is more than 65 years old or in patients with mild to moderate renal impairment. Some important adverse events to consider. We have upper respiratory tract infections, nasopharyngitis, headache, hypertension, increase in ALT, injection site reactions, and constipations. For monitoring parameters, we want to monitor neutrophils, platelets, liver function tests such as ALT and AST, and signs and symptoms of demyelinating disorders. There are also certain precautions that are important to take a look at as well. So serious infections, we do not want to administer during an active infection other than COVID. There's also GI perforation, so we want to use this medication with caution in patients who may be at an increased risk. And we also want to avoid live vaccines as well. For contraindications, we have patients with no hypersensitivity to Actemra. The medication is given IV, and it exists in 3 different concentrations, which are 80 milligrams per 4 ml, 200 milligrams per 10 ml, and 400 milligrams per 20 ml. Another IL-6 inhibitor that is used for patients with COVID-19 is seralutinib or Kevzara. The dose for this medication is 400 milligram IV infusion over at least 60 minutes. There are no renal dose adjustments necessary for this medication. Some important adverse events to consider are neutropenia, upper respiratory tract infections, urinary tract infections, increase in triglycerides, oral herpes simplex infection, increase in ALTs and ASTs, and injection site reactions. Some important monitoring parameters include neutrophils, platelets, liver function tests such as ALT and AST, a lipid panel, and also a latent TB screening is required prior to therapy initiation. There are no drug-drug interactions that have been identified based on the limited available data, and there have been no contraindications that have been identified as well. Initiation is not recommended for this drug in patients with absolute neutrophil count less than 2,000, platelets less than 150,000, and liver transaminases more than 1.5 times the upper limit of normal. This medication is given IV, and it exists in a concentration of 150 milligrams per 1.14 milliliters. Another class of drugs that is widely used in an inpatient setting are the Janus kinase or JAK inhibitors. The indication for this class of drugs is to treat suspected or lab-confirmed COVID-19 in hospitalized adults and pediatric patients more than or equal to 2 years of age with or without remdesivir who requires supplemental oxygen, invasive mechanical ventilation, or ECMO. For uses, we have this class of drugs is used in combination with dexamethasone plus remdesivir for patients with severe disease, not requiring mechanical ventilation, who are exhibiting rapid progression of respiratory failure with evidence of inflammatory mediator elevation. Baricitinib with or without remdesivir may be considered for hospitalized patients who require oxygen supplementation when corticosteroids cannot be used. Tofacitinib can be used as an alternative to baricitinib. So the first JAK inhibitor that we are going to discuss is baricitinib or Olumiant. The dosing for this medication is based on 2 factors. One is the age, and the other one is the renal function or eGFR. So starting with adults and children more than or equal to 9 years old, the dose is based on eGFR. So if eGFR is more than or equal to 60, we're giving 4 milligrams by mouth once daily. If eGFR is between 30 and 60, the dose is 2 milligrams by mouth once daily. And if eGFR is between 15 to 30, the dose is 1 milligram by mouth once daily. If eGFR is less than 15, we do not recommend using this medication. For children that are aged between 2 and 9 years old, the dose is also based on eGFR, but it's a little bit different than for the population described above. So if eGFR is more than or equal to 60, the dose is 2 milligrams by mouth once daily. If eGFR is between 30 and 60, the dose is 1 milligram by mouth once daily. And then for children that are between 2 and 9 years old, if eGFR is less than 30, we do not recommend using this medication. The duration of therapy is for up to 14 days or until hospital discharge. Some important adverse events to consider regarding this medication. It increases ALTs and ASTs. It could cause deep vein thrombosis, could cause pulmonary embolism, urinary tract infections, infection, and thrombocythemia. Some monitoring parameters include complete blood count with differential, renal function, more importantly the eGFR, since that's what we're using to dose the patient, liver enzymes, new infections, and hemoglobin. For precautions, we want to avoid concomitant administration of live vaccines. We want to avoid use in patients with active serious infection, except for COVID. And we also want to use this medication with caution in patients at an increased risk of thrombosis, since it can basically also have an adverse event of thrombosis. There are currently no contraindications that are available based on the data provided. And for drug interactions, we want to make sure that we do not give the JAK inhibitors with IL-6 receptor blockers, such as tocilizumab or seralutinib. This medication is administered by mouth, and it's metabolized via CYP3A4. It's also an inhibitor of OAT1, OAT2, and OAT3. And the formulation of this medication is as 2 milligram tablets. Initiation is not recommended for patients with an absolute lymphocyte count of less than 500, absolute neutrophil count less than 1,000, and hemoglobin less than 8. The other JAK inhibitor that is used for an inpatient population is tofacitinib or Xeljanz. The dose for this medication is 10 milligrams by mouth twice daily for up to 14 days or until hospital discharge. We also want to recommend a prophylactic dose of an anticoagulant while receiving tofacitinib. Dose modifications may be required in patients that have moderate to severe renal impairment or moderate hepatic impairment. Some important adverse events to consider are infection, nasopharyngitis, hypertension, headache, increased serum cholesterol, urinary tract infections, and anemia. For monitoring parameters, we want to keep an eye out on a complete blood count with differential, liver enzymes, and new infections. There are also some important precautions to consider as well, such as avoiding concomitant administration of live vaccines. GI perforation is possible as well, so we want to use it with caution in patients that are at an increased risk. And co-administration with strong CYP3A4 inducers is not recommended. There are currently no contraindications available based on the data provided. This medication is given or administered by mouth. It is metabolized by CYP3A4, which could possibly lead to some drug-drug interactions with other drugs that are metabolized by CYP3A4. The formulation of this medication, it comes in tablets that are 5 milligrams or 10 milligrams. And finally, an important consideration here at the end is that initiation is not recommended if the absolute lymphocyte count is less than 500, absolute neutrophil count is less than 1,000, or hemoglobin is less than 9. There are also certain medications that are recommended against in an inpatient setting. Those medications include hydroxychloroquine, combination of hydroxychloroquine plus azithromycin, a combination of lopinavir plus ritonavir, convalescent plasma, famotidine, bamlanivimab monotherapy, and ivermectin. So to finish up the section on therapeutic management of hospitalized patients with COVID-19, I have this quick knowledge check here as well. So which of the following medications is recommended in the inpatient setting that is not recommended for outpatient use? A, we have remdesivir, B is Paxlovid, C, dexamethasone, or D, all of the above. Just take a quick moment to look over the question and the answers and come up with your answer to this question. So the correct answer to this question is C, dexamethasone. As we saw in previous slides, dexamethasone is not recommended for outpatient use or in an outpatient setting, and it's usually used as the first line for patients that require supplemental oxygen in an inpatient setting. Other drugs, remdesivir and Paxlovid, they have been used in an inpatient setting and the outpatient setting, so those drugs can be used regardless of where the patient is, but dexamethasone is preferred for use specifically in an inpatient population. The next section that we're going to discuss is the drugs that are currently under investigation. So this slide depicts the drugs that are currently under investigation, and as you can see on this slide, they're all broken out in 4 different categories based on what category the drug belongs to. So for the first category, we have the antiviral drugs. This includes 4 different agents that are interferon alpha, interferon beta, interferon lambda, and nitazoxanide. The second category is the cell-based therapy, and currently under investigation in that category are the mesenchymal stem cells. The third class of drugs that's currently being investigated is the immunomodulators, and that includes colchicine, inhaled budesonide, inhaled ciclasinide, fluvoxamine, some interleukin-1 inhibitors such as anakinra and canakinumab, and finally an IL-6 inhibitor, which is siltuximab. The last category of drugs that's being investigated are the JAK inhibitors, and the drug that's being investigated in this class is ruxolitinib. Okay, so taking a look closer at the antivirals that are currently under investigation. Trials have not demonstrated efficacy for interferons in treatment of COVID-19, and some suggested potential harm in patients with severe disease. In a trial of hospitalized patients with COVID-19, interferon beta 1A plus remdesivir was not superior to remdesivir alone for hospitalized patients with COVID-19 pneumonia. For patients who required high-flow oxygen, they had worse outcomes after treatment with interferon beta 1A compared with those that given placebo. What you can see from that trial is that interferon beta 1A is not superior to remdesivir, and it can also cause some worse outcomes depending on the patient population. 2 trials are currently in the recruitment process to investigate antivirals in the use for COVID-19. Those trials are inhaled interferon A2B for the treatment of COVID-19 and pegylated interferon lambda for treatment of COVID-19 infection. Nitazoxanide had some trials that were investigated to see if it was efficacious for COVID-19, but further larger trials are required to evaluate efficacy in preventing progression to severe illness in patients at high risk. Moving on to cell-based therapy. Data on the use of mesenchymal stem cells in patients who have viral infection are limited to case reports and small open-label studies. There is a trial in the recruitment process currently, and it's called the mesenchymal stem cell for acute respiratory distress syndrome due to COVID-19. But the other trials that were finished did not come up with conclusive evidence that the mesenchymal stem cells are effective in the treatment of this infection. The last class of drugs that is currently under investigation are the immunomodulators. So the COL-CORONA trial showed that colchicine did not reach its primary efficacy endpoint of reducing hospitalization and death for non-hospitalized patients with COVID-19. Also, a recovery trial demonstrated no benefit with regard to 28-day mortality or any secondary outcomes for hospitalized patients with COVID-19. From these trials, you can see that colchicine has not been proven to be effective for patients with this infection, but other immunomodulators are currently under investigation for treatment of this specific patient population. A lot of healthcare professionals have been wondering if there are any respiratory therapies that can be used for this infection, since it primarily affects the lungs. From what we know, there are no respiratory therapy treatments currently available, since this is not strictly a disease that can be managed with typical respiratory medications. Among patients with mild to moderate COVID-19, inhaled corticosteroids fail to show or exclude a beneficial effect on mortality or COVID-19 related hospitalization. Among ambulatory patients with mild to moderate COVID-19, the IDSA guideline panel suggests against inhaled corticosteroids outside of the context of a clinical trial. In conclusion, Pfizer, Moderna, and Janssen are the main vaccines used in the United States to reduce the risk of contracting the COVID-19 virus. Tixagevimab plus silgavimab is the only medication authorized for pre-exposure prophylaxis of COVID-19. Therapeutic management of non-hospitalized patients consists of supportive care and Paxlovid, remdesivir, bebtelovimab, or molnupiravir, depending on risk factors and disease progression. Therapeutic management of hospitalized patients consists of supportive care and remdesivir, dexamethasone, tocilizumab, or baricitinib, depending on oxygen requirements and progression to severe disease. Certain medications are no longer recommended for use. In the outpatient setting, those include the combination of lopinavir plus ritonavir, ivermectin, or inhaled corticosteroids. In the inpatient setting, the medications that are no longer recommended for use are hydroxychloroquine, combination of hydroxychloroquine and azithromycin, convalescent plasma, and bamlanivimab monotherapy. The next two slides show the references I've used for this presentation, ranging from package inserts to clinical trials. Thank you for taking the time to listen to my CE presentation on current trends in COVID-19 treatment, and feel free to reach out if you have any questions or feedback. Thank you.